All right, we're going to talk about the upper and lower limbs, section 7 of chapter 8 on the axial and appendicular skeleton. You should be able to, after going through this section, should be able to identify skeletal features that are common to the upper and lower limbs and describe the functional reasons for differences between the upper and the lower limb skeletons. So the upper and lower limbs, they share common features based on evolutionary history. They exhibit differences based on primary limb functions. And the proximal part is supported by a girdle of bones, the pectoral girdle holding the upper limbs in place, and the pelvic girdle articulating with the lower limb, Thinking about the shoulder girdle, often referred to in the pectoral girdle as well. The upper and lower limbs similarities. The proximal part of each limb with one large bone. Distal part of each limb has two bones. There's an ability to slightly pivot at both the elbow and the knee a little bit. Knee gets a little more than the elbow. Elbow gets very little, and the knee can get a little bit too, but not a lot. The wrist and proximal foot contain multiple bones. They allow for range of movement. And the feet and the hands, both with 5 metacarpals or metatarsals, each with a total of 14 phalanges. The upper and lower limbs structural differences. The lower limbs are weight-bearing. They have some mobility is sacrificed for greater stability, whereas the upper limb is not weight-bearing. The arm and the forearm is relatively lighter. They're relatively more mobile. They're quite a bit more mobile, actually, from a general perspective. The hip has a lot more restriction than does the shoulder, generally speaking, but can be used for multiple activities for the upper limbs, and they're more mobile joints, a lot more mobile generally speaking, less stable, certainly can't support as much stability as lower limbs can. More frequently injured, of course. Anything that's more mobile and less stable, you're going to see a lot more frequent injuries generally speaking. The exceptions being, a lot of times when you have issues at a stable, injuries at a stable joint, it's because of the added mobility that's just offset by not proper stability, and that the variance creates an injury at the stable joint. That happens sometimes too. You should be able to identify and locate the clavicle and its landmarks, and describe the landmarks and the features of the scapula. The pectoral girdle articulates with the trunk for section 8.8 here, and supports upper limbs, and consists of the clavicles and the scapulae. The clavicle is the collarbone. It's an elongated S-shaped bone. It extends between the manubrium of the sternum and the acromion of the scapula, or the acromion of the scapula. The sternal end is roughly pyramidal. It articulates with the manubrium of the sternum. It forms a sternoclavicular joint or SC joint. The acromial end is broad and flattened. It articulates the acromion of the scapula. It forms the acromial clavicular joint. Then our superior surface of clavicle is relatively smooth, and the inferior surface is roughened. The conoid tubercle is the rough tuberosity on the inferior surface near the acromial end of the clavicle, and the costal tuberosity is inferiorly located prominence at the sternal end, closer to the midline, with the attachment of the shoulder's costoclavicular ligament there as well. So here we have the acromial end of the clavicle, the superior view, look at above here. Then you have the sternal end here, so coming toward the midline of the body, right? And then you have the conoid tubercle here, look at the inferior view, so looking from below it, the acromial end, so looking more at the shoulder there, and then coming across here more toward the sternum here, the costal tuberosity at the sternal end. The parts of the scapula, we have the spine, which is the ridge of the bone on the posterior aspect of that shoulder blade, so the scapulae for being multiple. And the acromion is a large posterior process forming shoulder's bony tip. It's continuous with the spine. The coracoid process is smaller and more anterior projection. It's a site for a lot of muscle attachment. Borders the scapula, we have the superior border on the uppermost border, the horizontal edge superior to the scapula spine, scapular spine. The medial border is the edge closest to the vertebrae. Lateral border is the edge closest to the axilla. And then we have the suprascapular notch, which provides for passage for the nerve and the blood vessels. The superior angle, for the angles of the scapula, superior angle is between the superior and the medial borders. The inferior angle is between the medial and lateral borders. The lateral angle is primarily made up of the glenoid cavity. It's a cup-shaped, shallow cavity. It articulates with the humerus. It's a glenoid fossa, is often when we talk about the humeral head meeting that for the shoulder, forming that shoulder joint, or the ball and socket joint there for that glenohumeral joint. The subscapular fossa is a broad anterior surface of the scapula. The subscapularis muscle overlies this fossa. Supraspinatus fossa is a depression that's superior to the spine with the supraspinatus muscle here. one of our rotator cuff muscles, as is subscapularis. And the infraspinous fossa is inferior to the spine with the infraspinatus muscle. All those actually muscles are formed as part of the rotator cuff. Now, that said, so looking at our scapula from the anterior view, the right scapula, you're looking at it from the front, okay? And we're looking at here, superior border up here, superior angle, okay? Suprascapular notch, coracoid process sticks out here. That bony process sticks out of the top here. The acromion here, okay? Lateral angle, glenoid cavity where the humeral head comes and meets here. The lateral border of the scapula, okay? And a medial border, more toward the midline. And the inferior angle, lowest angle, right? And then that posterior view of that right scapula, seeing it from behind, you have the spine of that scapula here, the acromion up here, the acromion process, right? Lateral angle here, looking here, the glenoid cavity, again, where that humeral head meets there, the coracoid process here, the subscapular suprascapular, notch, superior angle, superior border, supraspinous fossa, and the infraspinous fossa, the medial border, lateral border, and the inferior angle. So how do the sternal end and the acromial end of the clavicle differ? You should be able to answer that. And what fossae are located in the scapula, on the scapula, what is located in each fossa? Section 8-9, the last section of this video here that we'll cover, is bones of the upper limb. You should be able to describe the articulations of the humerus. You should be able to list the landmarks and features of the humerus, compare and contrast the features of the radius and the ulna, and explain how the radius, the ulna, and the humerus articulate. Also differentiate between the supination and pronation of the forearm, locate and identify the carpals and metacarpals, and describe the phalanges and their relative locations. So the components of the upper limb, we have our brachium or arm, antebrachium, the forearm, okay? The brachium technically being the humerus, and the antebrachium being the radius and the ulna, and of course the hand. The bones of the upper limb, we have the humerus, the 1 radius, 1 ulna, 8 carpal bones, 5 metacarpal bones, and 14 phalanges. For the humerus, it's the longest and largest upper limb bone. It's the proximal end with a hemispherical head, right? The epiphysis there, it articulates to the glenoid cavity of the scapula. And the greater tubercle is positioned lateral to the head on the outside portion, helps form the rounded contour of the shoulder. The lesser tubercle is smaller and more medial to the head. And intertubercular sulcus is between the two tubercles, and its depressions containing the tendon of the long head of the biceps brachii muscle. The biceps actually are affected by shoulder motion to some extent too. At least the biceps brachii is. Components of the humerus, the anatomical neck is between the tubercles and the head. The groove marking the location of the former epiphyseal plate. The surgical neck is a narrowing of the bone. It's immediately distal to the tubercles, and it's a common fracture site. The shaft of the humerus has a roughened area, the deltoid tuberosity. It extends along the lateral surface for half the length of the humerus, and there's where the deltoid muscle attachment occurs here. The radial groove is located adjacent to the deltoid tuberosity. It's the location of radial nerve and some blood vessels. Together, the bones of the humerus, the radius, and ulna form the elbow joint. That joint, place where two bones meet, the joint, right? Medial and 2 or more bones, really, but 2 bones, typically speaking. Medial and lateral epicondyles are the bony side projections on the distal humerus. Both the femur and the humerus will have that. They provide services for the muscle attachment there, and they're palpated on the sides of the elbow. You can actually feel them on either inside and outside your elbow. The ulnar nerve travels posteriorly to the medial epicondyle, funny bone. You hit that the medial condyle right there, that funny bone. You get that significant vibrating, uncomfortable pain that hitting that funny bone. Never fun at all. Components of the humerus still go in with the distal end now, the 2 curved surfaces. It's an articulation with the bones of the forearm. The distal end meets, right, at the elbow. The capitulum is located laterally. It articulates the radius, and the trochlea is located medially. It articulates the trochlear notch of the ulna. The distal end of the humerus has 3 depressions, 2 on the anterior surface, 1 on the posterior. The radial fossa is anterolateral placed. It accommodates the radial head, and the coronoid fossa is anteromedially placed. It accommodates the coronoid process of the ulna. And then the olecranon fossa is posteriorly placed. It accommodates the olecranon of the ulna when the elbow is extended. So we're looking at this here. I think maybe we'll keep this the same. Hope you can see this okay. Let's see how this looks here. I don't want to get too big. Now we'll look at this way. So we have our head of our humerus here, an anatomical neck, right? Intertubercular sulcus here going around. The greater tubercle protrusion there, or not protrusion, but like the edge there, and the lesser tubercle. Surgical neck goes around, intertubercular sulcus here. The deltoid tuberosity is we're talking about a lot of attachment for muscles, and deltoid muscles playing a role in attachment around the deltoid tuberosity, hence the name. And the shaft, the diaphysis of the humerus. The radial fossa here, the coronoid fossa here, lateral epicondyle, medial epicondyle, a trochlea here with the hyaline cartilage at the end there at that bony process end of that distal end of the humerus here, and the capitulum. And looking at here from the right humerus posterior view, this is the anterior. Now we can see that same head there again, the greater tubercle here, anatomical neck, surgical neck, deltoid tuberosity, radial groove right here, lateral epicondyle, olecranon fossa on the posterior side there, medial condyle, and the trochlea. So you're going to be able to identify anterior versus posterior, looking there, particularly both where the deltoid tuberosity is, and let alone differences in what you can see fossa-wise at the distal end. The radius and ulna form the forearm. The bones are parallel. The radius is located laterally. The components of the radius are a disc-shaped head at the proximal end and articulates the capitulum of the humerus. And the narrow neck extends from the head to the radial tuberosity, which is the attachment site for the biceps brachii muscle. The shaft of the radius curves slightly. It's a styloid process that's a bony projection at the distal end, right? Farthest away from the farthest end of that bone. And the ulnar notch, on the distal medial surface articulates with the medial surface of the distal ulna. The ulna is a longer medial place bone of the forearm, it's the pinky side. And it's a C-shaped trochlear notch at the proximal end, or you could also say in anatomical position it would be technically the medial side, but it's from your forearm perspective, it's on the pinky side. Interlocks the trochlea of the humerus. The olecranon is a projection of the posterior superior trochlear notch. It forms a posterior bump of your elbow. The coronoid process is the inferior lip of the trochlear notch and articulates with the humerus. And the tuberosity of the ulna is at the proximal end of the bone. The shaft terminates in a knob-like head, the posterior medial styloid process, and it may be palpated on the medial side of the wrist. For the radius and the ulna, the interosseous borders are facing each other. They're connected by an interosseous membrane with dense regular connective tissue. It keeps the radius and the ulna a fixed distance apart with the pivot of the rotation for the forearm. Now what's unique here, we'll talk more about the joints, is the radius technically rotates to the top of the ulna. The ulna can spin and rotate, but the radius actually goes over the top of the ulna when you pronate that forearm versus supinate. When you open up your palm, some people call it soup or supinate, like you're holding a bowl of soup, pronate, turning it internally, so to speak, with the radius rotating over the top of the ulna. Then we have our olecranon here, and the trochlear notch, the coronoid process, the head, right? And here at that radius, the ulna. And this in the neck here, the radius, and the tuberosity of the ulna, the radial tuberosity here. And we have the shafts, and it being the ulna, so you can see the ulna here, and the radius would be in this case on the outer portions of each of these. The interosseous membrane between, the interosseous borders, where the membrane attaches there at the radius and the ulna. Didn't miss anything up there, I don't think. Proximal radial ulnar joint, if I didn't say it before. And the distal radial ulnar joint here with the head there and there for this case for the ulna, okay, and the styloid process for the radius. Anatomic position, the palm of the hand is facing anteriorly once again. The radius and ulna are parallel in that case when you're in an anatomic position, when you're supinated open, if you will. Okay, the radius is on the lateral side of the forearm in this case. The ulna will be on the medial side in that position. The radius and ulna pivot along this interosseous membrane, and the palm of the hand is facing posteriorly when you rotate and actually pronation, right? You turn internally. And the head of the radius is still on the lateral side of the elbow, but you see how it looks like it actually crosses over. You can see this here. It actually does. It's the only place in the body where something like that happens. And it provides for greater mobility. You can't do this with the tibia and the fibula. This would not work. It can't happen. You would have to break something for it to happen, which would never be good. The distal and the radius has crossed over. The carrying angle is with the upper limbs extended and forearms supinated. Most people do arm curls without being in their proper carrying angle, putting added stress on both the shoulder and the elbow without understanding the skeletal structure that they have. Everyone's carrying angle is a little bit different. The bones of the forearm angle are laterally, the angle is lateral from the elbow joint. and positions so the forearms clear the hips during walking. It's simply if you slid up into anatomical neutral and open into your forearms into anatomical position, it'd be a natural position you'd be looking for to find where someone's carrying angle is. And typically it's wider in females, quite a bit wider, typically speaking. The carpals are the wrist bones. They allow for multiple movements at the wrist. They're arranged in 2 rows of 4 bones each. The proximal row from lateral to medial, scaphoid, lunate, triquetrum, pisiform, and the distal row from lateral to the medial, and the trapezium, the trapezoid, the capitate, and the hemate. The metacarpals are the bones of the palms of the hand. They articulate with the distal carpal bones. They support the palm. The Roman numerals 1 to 5 denote the metacarpal bones. And the metacarpal 1 at the base of the thumb and 5 at the base of the little finger, or V, right? 3 in the second and through the 5th fingers, phalanges, 2 phalanges in the thumb, right? 3 in the rest. That's the pollex. And the proximal phalanx is articulating with the head of the metacarpal. The distal phalanx is at the tip of the finger, and the middle phalanx is between the proximal and distal phalanges. So we have our radius, our ulna, radius being thumb side, ulna being pinky side. We have our trapezium here, our trapezoid there, our capitate here, our hemate here, pisiform here, triquetrum, lunate, scaphoid, okay, part of the carpals, which you'll need to know. These are all part of the carpals. And then basically we have then our metacarpals here, 1 to 5, starting with the thumb side going to the pinky. Then we have our proximal phalanx on the thumb side, the radius side, and we have over here the proximal phalanx here. We don't have a basically a middle phalanx for the thumb, but we do for the other fingers, right? Proximal phalanxes, middle phalanxes, and then the distal. Scaphoid bone and scaphoid fractures is a more commonly fractured bone. It can fracture from a fall, from outstretched hand. Happens unfortunately all too often. Blood vessels are torn, resulting in avascular necrosis. It incurs a death of bone tissue due to inadequate blood supply. It results in a long healing time. It braces our fall. It's a good thing, but it also can cause some serious damage too. So what did you learn? What's the difference between the anatomical neck and surgical neck of the humerus? What features on the humerus articulate with the radius and the ulna? What are some bony features the radius and the ulna share? Describe how the radius and ulna are positioned when the forearm is pronated. List the 8 carpal bones. Which of these bones may be prone to developing avascular necrosis if fractured? And that's section 8-9, and only a couple more sections here to go for the entire axial and appendicular skeleton. 8-10 will come up shortly.